And and clearly, side by side with that is what kind of consent processes are going to be in place. But we also raise, I think, very serious concerns that are already with us as data repositories are being developed to forward the research agenda, which have to do with stewardship and governance. Who's watching the data? Who's deciding what researchers get access to the data and for what kinds of questions? I don't know how much you are aware, but if we look at dbGaP, which is a federal data repository that seeks to, in fact, become an engine of genomic research precisely for the goal of improving healthcare outcome, there are very few minority samples in dbGaP. Why is that? Well, it's likely because we have lower participation amongst minority populations in research and greater mistrust amongst minority potential participants in research. And unfortunately, when we try and get to the bottom of where that mistrust may be stemming from, there are reasons for it. There are reasons for being concerned about how research has been done, or how research has been done without consent, how research data have been collected, how research data have been interpreted, and in particular how they've been interpreted in context of societal stereotypes that are harmful to disadvantaged communities. So what I want to say is, if we're going to embark on that kind of very ambitious large-scale research project, all of the issues I've just mentioned are on the table. We're not going to be doing a good job if we don't include diverse populations, and we're not going to be able to include diverse populations if we don't explore deeply reasons for mistrust and strategies for overcoming that mistrust. Those strategies, I think, will have to include stakeholder engagement. How do we talk together about what the research is about? How do we, the researchers at the university, bring communities into the process to help us plan the research and help us interpret the research? I would say these are going to be really essential elements of even testing the hypothesis that we're hearing today. Let me talk about another issue, and that's under the heading of non-maleficence, and that is preventive care is a great idea, and it's a wonderful thing to use tools to predict who's at risk in order to take special actions. We have incredibly dramatic examples of that. Let me just use a few examples from newborn screening, which is the largest screening program in the country. PKU, most of you are probably familiar with the example of PKU. We have a situation where we're able to identify a small number of kids, 1 in 12,000 approximately, who have a molecular problem. They can't handle phenylketones and phenylalanine. And they really need a modified diet that's low in phenylalanine in order to do well. If they don't have it, they develop profound mental retardation. If they do have it, they can lead normal lives. And this is really why we have newborn screening programs, and it's miraculous. And what we might be imagining with ideas like P4 medicine is the ability to extend that kind of benefit. But we have to be very cautious about the predictive value of the biomarkers we use. So let me tell you another story about newborn screening, and that's the story of newborn screening for neuroblastoma. Neuroblastoma, bad disease, kills infants. It's a certain kind of tumor. Early in the 1980s, researchers identified a biomarker that was able to identify kids with neuroblastoma. And several jurisdictions jumped on it and were very excited about the possibility of identifying kids early with neuroblastoma in order to treat them, in order to cure them, and improve outcomes. Things didn't turn out the way people had hoped, and fortunately the outcomes were studied. So for example, there was a large area in Canada where this kind of newborn screening was implemented, and they were still seeing some cases of neuroblastoma coming through, so they began to investigate. Their investigations included a several-year comparison of neuroblastoma mortality in the place where screening occurred versus in 4 other very demographically similar locations. No change in neuroblastoma mortality. They identified cases that were coming through that were being missed by screening. Those cases tended to be the more severe end of the spectrum. They identified kids who'd been identified with neuroblastoma, and in retrospect, the tissue characteristics were on the mild side, and some of these kids died or suffered disability from their neuroblastoma treatment. This is a cautionary tale for the use of biomarkers to predict outcome and to take action. We have to be very cautious about the predictive value, I would argue, particularly for complex diseases where whatever we find in the biomarker early in disease is only part of the story. We have to be cautious.
So I can be brief on this because I think I agree with every single word that Professor Burke just said, including the ands and the thus. Clearly, I mean, we have to be very careful about the predictive value of biomarkers. But that's not an argument for not proceeding to work with biomarkers and deploy the information after it's been properly vetted and analyzed and by scientists and by medical professionals who set standards. And clearly, all of the ethical concerns that we have about working with people and getting information from them and processing and delivering it back in a way that's actionable, I couldn't have described it better than Professor Burke did. But we have to go forward and we have to tackle these problems. And we can't just say, okay, all of these are problems, therefore let's not move forward. I personally am very concerned about the fact that personalized medicine, may turn into something for rich folk. And that would be truly unfortunate. And I think it would be a real, it would actually be economically inefficient, because one of the things I think personalized medicine can really do is really help some of the folks from our more disadvantaged communities and have a major impact on global health, because it teaches us how to work. It'll teach us cumulatively how to work with communities, how to give them information, how to help them work with it. So I don't disagree with any of that. We simply have to deal with those problems when we go forward. So in terms of the projects that we're thinking about, there's going to be a lot of effort to do just that. So let me just say a couple of words just to pick informed consent. So the informed consent model right now is informed consent is kind of a discrete event. It can be a long conversation, it can be a day, it can be however long, but it's a discrete event where you give people information and then essentially you get a signature on a piece of paper. Mm-hmm. We don't think of it that way. We think informed consent really is part of a dialogue, and it's a dialogue that goes on and it never stops. So in these kinds of P4 medicine projects, one of the main focuses is going to be keep the dialogue open and keep talking with everyone. I mean, look, you have to do that when you're continually giving them different kinds of information and trying to help them use it, and learning from them about how they can use it effectively and what works and what doesn't work. So the dialogue about what's going on in research and all of that has to be continuous, it has to be ongoing. I see 2 main ethical problems. One, we have to have relationships between the clinical institutions, the science institutions, and the people that they're servicing that everyone perceives to be fair. And perceives to be fair not just to sign a piece of paper, but for years, for decades. How we do that, we're not 100% clear, but it's going to involve a lot of communication, clearly. The other thing is that it has to be perceived that it's safe. We have to protect everyone that's involved in this. So that's something that we all take very seriously. But things like privacy are also a moving target, because expectations of privacy of the population will change. So that will take continuous kinds of dialogue. So a lot of these efforts is to build in the mechanisms to have these kinds of dialogues. Exactly how are you going to do it? We're not clear. And frankly, I think that we're going to ask the people that we engage with how they want to do it. Because that's what you have to do. You have to ask them, what's the easiest way for you to communicate? How do you want to get information? What information do you want? What information do you not want? These are the conversations that are going to have to take place, and they're going to have to be institutionalized.
I agree. I agree with that as well. And I think it's interesting. We're hearing a lot about education and communicating results. And again, genetic information is very esoteric. So when you're talking about the return of results from a sequencing project or an array project or anything like that, you're dealing with some really murky water. And